Hello and good afternoon to everybody. Again, thank you for being here for our fifth European webinar on the topic of domestic violence. And thanks also to the fantastic group we are working with. Like the other webinars, this will be recorded too. During the presentation, we will have a few moments to share our experiences by writing in the chat. So today, we will focus on the basic info for medical assessment and documentation in case of domestic violence, including the screening as a special aspect of sexual violence. After this webinar, you will have an overview about how suspect cases of domestic violence need to be documented and how medical exams should be carried out respectfully. We will present legal and ethical aspects in case of domestic violence, the importance of medical forensic documentation. We will highlight key aspects of sample evidence collection, the role of photography, and we will provide you with important tools for discharge and follow-up. First, I'm going to introduce myself and my co-speaker. I am Emilia Solinas. I am an interventional cardiologist and psychotherapist, and I work in Parma University Hospital, for which I lead a gender medicine and corporate welfare program with the Equal Opportunities Committee. And since January, I am also the president of Parma section of AIDM, which is the Italian Association of Women Medical Doctors. And it's my pleasure now to introduce Antonella Vezzani.
Hello to everyone. I am Antonella Vezzani. I am anesthesiologist. Now I am retired. I was the chief of cardiac surgery intensive care unit at the University Hospital of Parma. Now I am the AIDM National Past President and the Equality Advisor of the province of Parma in Italy. My experience with domestic violence comes from having led the Equal Opportunity Committee at the Hospital of Parma, and in 2012 having established the first procedure for the care of women victims of violence by creating a working group composed of emergency doctors, gynecologists, midwives, nurses, forensics doctors, psychologists, and social workers to ensure adequate support for victims of violence.
So let's dive into the topics. To begin with, I would describe the risks and potential harm that the healthcare system may cause if domestic violence is not recognized by showing you the medical power and control wheel. In this wheel, different elements are illustrated, which can all significantly escalate danger and increase the level of entrapment of the victim. To begin with, in the upper center corner, violating confidentiality. If the physician or the nurse interviews the patient in front of family members or each time telling colleagues issues discussed in confidence without the patient consent, or calling the police without consent from the patient. Trivializing and minimizing the abuse, not taking seriously the danger being experienced by the patient, asking for tolerance because of the number of years in the relationship, blaming the victim, asking the patient what they did to provoke the abuse, putting the patient at the focus of the problem, and asking, for example, why don't you just leave? Why do you put up with it? Why do you let them do that to you? Not respecting the patient's autonomy. For example, prescribing divorce, sedative medications, going to a shelter couples counseling, or the involvement of law enforcement punishing the patients for not taking the advice provided. Of course, ignoring the need for safety. And finally, normalizing victimization. For example, failing to respond to the patient's disclosure of abuse, acceptance of intimidation as normal in relationship. Now, we want to come in the discussion. So we are going to ask you, in a scale from 0 to 10, and 10 means very confident, how much you feel confident of being able to take care of a victim of domestic violence. So you can write your number in the chat, and we will discuss the results in a couple of minutes. So please be free of writing in the chat.
Well, on the scale from 0 to 10, most answers are under 7. Only 3 people write 8. The result underlines that most of you, also aware of the need to take care of women victims of violence, do not feel safe enough in taking care of victims. It's understandable that you may not feel prepared, as no one has received the specific training. But please be aware that medical professionals are often the first or the only professionals interacting with individuals affected by domestic violence. They have a special responsibility and a valuable opportunity to intervene. Let's dive now into what we need and have to do as healthcare professionals taking care of patients, potential victims of domestic violence. First, a medical history needs to be taken. Of course, we all should follow standard medical procedures, but it should be remembered that victims who experience domestic violence are likely to be traumatized. Any medical report should be checked, and we should avoid asking questions they have already answered, the so-called secondary traumatization. Every aspect of the examination should be explained. Informed consent should be obtained for every aspect. Inform the victim that preserving evidence can significantly contribute to the legal process if the person should decide to report to the police. A complete physical examination should be carried out. Findings and observations should be recorded clearly and concisely with the help of body maps. The findings in the patient medical records are to be documented in the patient's own words, but further questions should be also asked. How to document domestic violence in the health sector? Let's have a look to a short video from Improdova.
How to document domestic violence in the health sector. As well as recognising and responding to possible experiences of domestic violence and putting in place any possible protective measures and onward referral to services, a key role for health services is providing comprehensive examination and documentation fit for any potential court process of medical findings, including indications of physical and sexual violence. Medical documentation that can be used in court may be important for prosecuting domestic violence cases, including as evidence of physical violence. Always use a documentation sheet and evidence collection kit for documenting injuries and securing evidence. You should make sure your documentation is understandable to lay people, as it will be used in the court process primarily by people without medical training, such as lawyers, police, and the judiciary. Document descriptively, without interpreting findings. Your documentation should contain the following key elements: background information about the medical exam, anamnestic information, assessment and description of any injuries, as well as photographs. If possible, document injuries before medical treatment is provided. Where immediate treatment is necessary, consider whether it is possible to photograph the injuries first. Where there is a possibility of sexual violence, preserve trace DNA and other materials such as clothing. Clarify whether the patient has already or would like to report matters to the police. Ask about the patient's safety and protection needs and those of any children. If there are signs that the patient is not safe at home or otherwise does not want to return home, refer them to support services.
So there are some very important aspects in this video that we want to highlight and should be emphasized. Performing the examination in a respectful way. Always keeping in mind the mental issues considerations, how to deal with accompanying persons, especially if a language barrier exists, and finally, keeping in mind that in this situation, waiting times must be minimized. But how can we perform a medical assessment in a respectful way? Of course, in cases of serious injuries, the primary emphasis should be on the injury treatment, with evidence collection coming after. But we have to keep always in mind that we have to reduce the power difference. But what does reducing power difference mean in a medical examination, and how can we conduct the visit? An example is sitting on a low stool. So we sit nearby the patients, we are near the patients, but at the same level, not standing over the patients or hanging over the patients. By giving the patient control option and telling him or her that there is the option to stop at any time, or asking for permission and let the patient know what we are going to do next at each step. Asking if there are any parts of the exam, such as breast or pelvic, which are particularly difficult to examine for the patient, and ask what we could do to make the exam more comfortable. And keeping on explaining and encouraging question, asking periodically about anxiety levels. It is essential to maintain eye contact, of course, if culturally appropriate. And we should remain patient why we are performing the exam and explaining the benefits to her or him. Allowing extra time is crucial. We also have to keep in mind that many victims of domestic violence will have emotional or mental health problems as a consequence. So it is essential to refer them to specific health services that can offer help and specific techniques to victim survivors by reducing their stress level and promoting healing. Some victims, however, will be more severely traumatized than others immediately during our observation. So in these cases, it is important to be able to recognize these victims and to help them to immediately obtain trauma-sensitive care and communicate in a trauma-sensitive way. What about the accompanying person? So, if the patient is accompanied by someone who may be the perpetrator of violence or has a close relationship with the perpetrator, we must not allow them into the examination room. So, when taking the medical history during the examination, clinicians must ensure the patient's ability to speak privately, either alone or with a chosen support person or victim advocate. And if the patient has a personal care attendant, the patient should decide if the attendant should accompany him or her during the examination. So, the clinician should initially screen the patient alone to provide the option and avoid assumption about safety. Caution is necessary as family members, friends, and care attendants may pose risks, including being the source of violence or conveying information to the perpetrator. And if the patient does not speak our language or does not speak it properly, we have to ensure professional language mediation because family members are unsuitable for this task. And finally, again, we have absolutely to avoid waiting times, especially for victims of sexual violence and individuals reporting an assault on the neck, like strangulation. Conducting in-person screening for domestic violence has proved to be effective, especially when using a valid and reliable screening tool in a private, one-to-one environment. So incorporating domestic violence screening as a routine element of patient visits enable clinicians to address domestic violence within the healthcare context and underscores its prevalence across diverse patient population. It's not simple. Here are some examples of useful sentences in daily practice. For example, we could say, violence can be a problem in many people's lives, so I now ask every patient I see about trauma or abuse they may have experienced in a relationship. Or another sentence, many patients I see are coping with an abusive relationship, so I've started asking about domestic violence routinely. Finally, another example that we can implement in our clinician routine. I've started talking to all of my patients about safe and healthy relationship because it can have such a large impact on your health. Now, please come again into the discussion. We would like to ask you to think about some examples of comorbidities which could heighten the likelihood of being a victim of violence.
You identified a lot of conditions that increase the risk for domestic violence, including cognitive difficulties, dependent personality, having disability, not having a legal status in the country where they live, depression, anxiety, increased perception of pain, people who are isolated from family and friends for various reasons. There are a lot of conditions that may increase the risk for domestic violence, but disability is very common, is a very grave problem for these people. A study revealed that even so, 90% of women with various disabilities had encountered violence in their life. Only 15% had ever been questioned about abuse or suffered by a healthcare provided. So it's crucial to screen patients with disabilities privately before involving a personal care attendant or intimate partner for communication or mobility assistance. Screening should be broadened to encompass potential abuse by personal care attendant in addition to domestic violence. Before we start with documentation, we always have to clarify whether a sexual assault and thus evidence collection is the primary focus of the documentation. Always use a specific documentation sheet and evidence collection kit for documenting injuries and securing evidence. If possible, document injuries before the patient receives medical care. It's essential that we document in a purely descriptive way. We have to refrain from interpreting findings such as estimating the age of the wound or assessing whether an injury was inflicted externally. Photography are particularly informative and can supplement written documentation. What should we always describe in our medical records? Of course, general conditions like nutrition, irritation, emotional and psychological state of the patient. The type of injury. Is it a scar, a bruise, an abrasion, an excretion, an hematoma, continuous solution, lacerated wounds, burns, broken or ruffled teeth, rupture of the tympanic membrane, which is very typical when unilateral, usually due to violent slap. We have to describe also morphologies of injuries according to the method used to produce, for example, nailing, biting, cutting, manual grip, constriction, whipping burns from cigarettes. Describe also the location of injury and always specify whether you find them in an atypical location for accidental report trauma. Pay attention to lesion in the head and face, eye, nose, mouth, back and palm of hand, nails, thorax, back, genital or perianal area. The number of lesions is also crucial, and often the findings may be occasional. Sometimes the lesions are so numerous that their description is better identified in a body map. Chronology of the lesion is very important, as well as the detection, often occasionally, of lesion in different development stages. For example, the simultaneous presence of fractures and bone calluses, scars and continuous bleeding, or under scrapes, ecchymosis and hematomas with very different color evolution. There are all signs of development lesion lasting since long time. Remember, in case of physical abuse during pregnancy, a gynecological obstetrical examination must be carried out, assessing the state of health of the woman and of the fetus.
So here you can see an example of an injury location chart, a body map, like Antonella said. What we have to remember is that documentation must be easily comprehensible for non-medical professionals, including lawyers, police, and members of the judiciary. So we have to avoid abbreviations, complex medical terminology, and ensure clarity and accessibility. Every time that we can do it, we should first document and then supply. If treatment of injuries has higher priority, we should always check whether photographic documentation of the untreated injury is possible. Another important note that we must remember is that giving a psychiatric diagnosis may be used in court against a patient in a custody battle. So we have to be sure when we declare it and include a relationship of abuse together with the psychiatric symptoms, as well as the efforts patient has made to protect herself and children. Let's see how can we describe lesions in a victim of a domestic assault. As you can see in the picture, we have to describe each injury in the dimension, localization, shape, boundary, size, color, and shape. And whenever is possible, as Antonella said, we have to use a table to describe the findings and draw each injury in a body map. And this is very important because it will give us an overview of the location and, if necessary, the concentration of multiple injuries on the body, on the part of the body. Always include information about what hospital forms, what lab, and what X-rays have been ordered, and the name of investigated physician, and which actions were taken. When describing it is very important that we refrain from interpreting documents must be purely descriptive and refrain from interpreting findings such as estimating the age of the wound or assessing whether an injury was inflicted externally. Instead, we have to use neutral language. We always have to write patient states rather than alleges. We always have to use the patient's own words, in quotes, and do not include extraneous comments patient makes. The situation can be described in detail, and for this is very useful the 5W question tool. So asking always who, what, when, where, how, especially when talking about threats, weapons, or objects used, and about witnesses. Finally, remember to describe all the patterns of abuse and threats and physical and mental health consequences. Here are some examples of written documentation, and it is essential, as you can see, that we avoid legal terms or those that imply disbelief or judgment. On the left part of the screen, for example, we can read on the left part, we must not say patient alleges that her boyfriend burned her with a curling iron. Instead, on the contrary, on the right part of the screen, we can see how we should write, how we should use terms that are objective and descriptive if helpful. For the sentence that we have read, for example, we should write, patient states that her boyfriend Robert grabbed her curling iron out of her hand and held it against her neck. Again, another example. We must not say, for example, on the left, patient denies that boyfriend burned her, claims that she burned herself. We should, on the contrary, as you can see on the right part of the slide, physical findings of a burn are of size and shape consistent with the report that it was caused by a curling iron. Severity and location of the burn appear inconsistent with patient's report that she burned herself. Other examples of good or bad written documentation. Again, on the left, writing that multiple hematomas all over the face were present is not a court-proof documentation. Instead, on the right, a court-proof documentation would be and should contain all the information about number, size, positional relationship to anatomical fixed points of the lesions, the appearance and coloring, and whenever is possible, the picture.
Which is one of the most important aspects for documentation. Apart from general data, anamnestic information, and the survey of findings, remember that an investigation is particularly urgent in case of suspected assault against the throat. Whenever we see strangulation or choking sign, because this in terms of criminal law may be an attempted homicide. The injuries which arise the suspicion of strangulation sometimes disappear quicker, so it's real crucial to document this kind of signs. Here are some common examples which you can see in this slide. Signals of stasis bleeding like petechia in the eyelids and conjunctiva, or in the oral mucosa, or in the posterior ear region, are all signs of relevant reduction of blood outflow and must always be examined. Always investigate and report if a temporary consciousness loss happened or a loss of control of the excretory organs. And if the patient reports a sore throat, difficult swallowing, and the globus sensation. When documenting sexual violence, remember that apart general appearance and the functioning of the individual, mental status, drug effects, level of cooperation should always be documented, as well as the identity of the examiner and the data, time, location of the examination. We should write down any limitation to examination, like lighting or inadequate cooperation from the victim. A comprehensive examination should be performed directed to the history provided. All recent and old injuries should be recorded and described in detail, recording any pertinent negative findings. A note should be made of any specimen collected, photography undertaken, diagnostic text ordered, and treatment initiated. The individual should be given a detailed explanation of the findings and their treatment and follow-up. Of note, the victim should be informed that some injury might become more visible after some days, and that if this happened, she or he should return for examination and documentation. In case of sexual violence, this is part of the medical assessment and the securing of evidence, collecting samples for the toxicology examination, considering the possibility of unknowingly administered, securing clothing that was worn at the time of the crime, performing genital or anogenital examination, including vaginal examination, examination of the male genital and anal examination, clarifying whether emergency contraception is necessary or wanted, considering and treating the risk of HIV infection or another sexual transmitted disease. A special consideration must be highlighted about the difference between consent and confidentiality. The consent to undertake the examination should always be obtained from the individual. The consent should be specific to each procedure, and particularly for the genital examination, to the release of finding, a specimen, and to any photography. The victim may consent to some aspect and not other, and may always, in every time, withdraw consent. The consent should be documented by signature or fingerprint. Confidentiality of the medical and forensic examination is, on the contrary, governed by specific privacy law, which vary based on the patient age, circumstances, and the examination location, with potential difference between countries. Generally, physicians have the legal duty to respect patient confidentiality. Please go to the national adaptation of the platform to get the national legal framework and work of the VIPROM. Well, now another question for you. Would you feel able to visit a victim of domestic violence on your own, or would you prefer to call in the forensic physicians for counseling? Please type yes if you do feel able, or no if you don't.
Okay, Antonella, which is more prevalent, yes or no?
Half yes.
Oh, good.
And it depends also on the situation. Yes, because of course in hospital it's more easy to have the physician, the forensic physician, while in pre-hospital is very difficult. Okay, this they obviously depend on the experience. However, I suggest do not hesitate to involve experienced personnel if they are available. However, not all hospitals have a forensic physicians available on call, so it's necessary to be informed about the procedure to follow.
So in other words, what we can say is that forensic documentation goes beyond regular medical documentation. So it is of great importance for the criminal prosecution of the offense and can significantly support victims, for example, in clarifying questions of access and custody or in questions of residence law. Unfortunately, as Antonella said, it is not always available, and in fact, medical documentation of findings is often the only proof that victims have experienced physical domestic violence, in particular for victims who want to report the crime at a later point in time. So therefore, it is essential that every physician examining a potential victim is able to document carefully in order to provide a valuable basis for any testimony that may be given later. And documentation that can be used in court needs to be confidential. So keep in mind that when we have available a professional forensic documentation is of course the key evidence for the court proceeding, but we must be aware that if we don't have it, we have to do a document, a court-proof document yet. So that's why it's so important that we all become skilled in the description of physical assessment. We can go with the next slide. For example, not only the lesions, and as we told you, that must be described, but for example, any damage to auxiliary aids such as wheelchairs and present safety concerns and needs. We have to be able to describe the dangerousness, the lethality of the lesions and risk assessment depending on the type of the tool used. Particular attention, as we can see in the picture, must be paid for lesions beyond the head, and the neck must be investigated. Oral and scalp examination must be performed, as well as patient's neck measurement. And we also have to check if tongue and oral injury is present. And finally, we have to check if a cranial nerve deficit is present. Photography is a useful tool for medication, for medical documentation of injury, as well as memorializing damage to a patient's clothing or other belongings. However, should a patient decline a photograph to be taken or one organization does not have camera equipment available, the clinician can still perform a comprehensive medical forensic examination, relying on a narrative documentation and body diagrams. That's why it's so important to learn all the tools and all the procedures, because forensic examinations are important, but are more than a photographic catalog of injury. So when documenting the injury with photography, we have to use a digital camera with proper settings. We have to take at least 2 photos per injury, and we have to review the displays for clarity and completeness and take additional photos if uncertain. We have to safely store all photos, and we have to photograph sensitive body regions only if clear findings exist of lesions, avoiding complete images of genitals. So this is quite a complex flow chart, but let's try to see it together, because the important step is to understand the time of presentation of the victim. So the time of the presentation is within 120 hours of an intimate partner violence, and it was a sexual assault. We have to offer a complete medical forensic examination and evidence collection. On the contrary, if the patient has not been sexually assaulted, we have to check if the patient has been strangled or beaten. If yes, in these examples of protocol, we should collect 2 swabs from each wound and collect 2 swabs from the affected area of strangulation and secure each set of swabs separately. If the answer is no, so we mean that the patient has not been sexually assaulted nor has been strangled or beaten, we have to pay particular attention to the collection of potential samples which may need to be collected for future evidence. For example, bloody clothing, swabs of nails from defensive injuries, or other items per the patient's history. If the answer is no, so if the patient does not present within 120 hours of the assault, so presents later, we have to check if the patient has clothing which has been damaged in the assault. And if clothing is present, we have to collect it in individual paper bags. If not present, we have to offer a complete IPV medical forensic examination with no evidence collection. So now, last question for you. So when you visit a victim of domestic violence, what task do you find most difficult to perform between screening for domestic violence in suspected cases, collecting evidence of violence, or reporting signs of violence in the medical report. Which task is more difficult for you? You can rank the items in order of difficulty. Please write it in the chat and we will back to you to comment your answers.
Well, the winner is the answer number 3. Reporting sign of violence in medical report. It's surprising because I think that we are doctors, so we are used to report sign on medical report. But I think that this is only an easy task on the surface, but we must remember that our report will be used in court. So we must take the greatest care in describing also injuries and the situation by the victim, as Emilia explained. The second most difficult task is collecting sign of evidence. Collecting signs require careful assessment, and we must not forget to collect signs that may not be of clinical interest, such as scratches or bruises. And someone also said that the first is the most difficult task. But maybe that this is not a difficult task, but this is also very important. If we fail to bring out the request for help, we will not have the opportunity to intervene. As Emilia said, incorporated domestic violence screening as a routine part of patient visits allows doctors to address domestic violence in the healthcare setting. And now we speak about discharge and follow-up. We have to provide the patient with a copy of documentation sheet and photos if requested, and address a security issue regarding storage, especially if we fear the possibility of access by the perpetrator. We have to point out that he or she can use the copy for as long as she or he wishes. It's crucial that we ask about the patient and, if applicable, their children's safety and protection needs. If there are indications of a possible risk and if the patient does not want to return home, we have to refer him or her to support facilities. We have to inform the patient about psychological counseling services for coping with violence, assist in making contact, schedule an appointment at specialized counseling, and provide written information on managing the experience. Finally, always consider the red flag for high risk and follow the local protocol.
So here you can find more information with a spotlight on gynecology and obstetrics issues or emergency department setting, including surgery and pediatric. And here you can find another focus on dentistry, which will be also the focus on one of next webinar. So time flies, we need now to wrap up. We hope that the messages that we gave you, which are all included in Module 4 of the platform, will be useful for clinical practice. What is really essential to know is that we are professional, which are often the first or the only ones interacting with the individuals affected by domestic violence. So we have a special responsibility, but also, as Antonella said, a valuable opportunity to intervene. That's why we need the training. We need to know how to do. We need to know how to deal with this kind of very special patient who are so delicate. Also for our health and good work, self-care is also mandatory. In other webinar, our colleagues have been talking about this and is especially written in Module 9. So you can find all the information about we told you on our European training platform on domestic violence.